All right. Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. Here at Doc Buddy, we deliver healthcare solutions that take the pain and cost out of broken workflows, like with OpNote, which gives ASCs the power of instantly generated operative reports approved from the point of care. You can learn more about OpNote and all of our solutions at docbuddy.com. And today I'm really happy to have Rena Courtay back on the show. Rena joined us, a few dozen episodes back at this point. For those that need a refresher, Rena is the VP of Ambulatory Surgery at Trinity Health, and she's also an officer on the ASCA Board of Directors. Rena, thanks for making a little more time for us.
Well, thank you for having me, Eric.
Our pleasure, and it's fitting that the last time we saw each other was at ASCA in Denver, just a month or so ago. Time is flying.
It does.
Another great event, obviously. Great venue, too. It was kind of nice to not be on the East Coast for this one.
Yeah, I think we got a lot of great feedback from people that liked the venue a lot, and it was our biggest attendance ever, so it was exciting.
Yeah, it was kind of funny talking to some of the organizers of the event, Chris and Alex, among others. There was concern about getting to Denver, and I'm thinking that's a direct flight from just about anywhere in the country. So definitely the attendance bared that out.
Yes, it's pretty easy to get there.
And we're together today to talk about solving all of the biggest challenges in healthcare in one fell swoop. It ought to be pretty easy to tackle some of these things, but at the top of the list is this recurring theme around the shortage of anesthesiologists, the shortage of CRNAs, and then something that's not getting quite the publicity that it should, in my opinion, but I'm sure that it will soon, is just the outright shortage of physicians, non-anesthesia physicians. So, Rena, get out your magic wand here. What do we need to do to fix this problem?
Yes, let's solve it today. Now, we are seeing the anesthesia shortage at all of our sites. We're feeling the impact of that across the country at Trinity, and we have 101 hospitals in 27 states. So we see this. And, on top of that, we're seeing it much more broadly in the ASC industry. 2-3 years ago, you never heard of ASCs having a problem. In fact, you're like, oh, let's get proposals from 3 or 4 anesthesia groups, pick the one we like, because you could just really do that, and you would never be paying a subsidy. The hospitals have always paid one, I think, but we have not. And now almost every ASC I talk to is either paying a subsidy or they're being asked to pay one. And that's including big companies like HCA and SCA and others that have not historically had that problem. But we have to be creative now, and you have to think about a lot of things that you didn't think about before, such as how do you run your schedule and how do you run it very efficiently, because you're going to be paying for this anesthesia time, and their salaries have skyrocketed. When we compare them on the MGMA, salary, we have to do fair market values, of course, of all their salaries before we enter into any contracts with a subsidy. So I've become very familiar with what are these salaries. And, some markets like Chicago is really high. They'll be at like the 90 percentile of all salaries for anesthesia CRNAs in that market. And this is almost double what I would see salaries a few years ago for these CRNAs especially. And so how do we make our schedules more efficient? That helps us as well. We should have always been doing this, but we weren't, because we could just get anesthesia to come in and do one case. If we wanted to, a doc wanted to do one case, we'll open a room. Okay, good, we'll do it. We can't do that anymore, because that's not cost effective for anybody, and it's real. You're going to end up paying anesthesia more than you get reimbursed on the case. So looking at vertical scheduling, looking at do we need a free MD like we've always had in the past? A lot of places have had the model where we've had one free MD, 4 CRNAs, one MD for every 4 CRNAs, and the MD, unless they're doing blocks all day, they probably have a lot of free time. We can't even afford to do that anymore, unless you're doing, like, you have a heavy orthopedic center and you have to have someone doing blocks all day long. Then that's a different story. But then you're probably doing okay because you're busy all day long. But it's become, you just have to look at absolutely everything. Some states allow CRNAs to practice independently. And in those states, we're getting more and more locations where we just don't have an MD at all
Right.
because we just can't afford it. And so states like Idaho or Iowa, where you're allowed to have CRNAs practice completely independently, that's becoming more commonplace. And CRNAs are opening their own groups without any MDs. So there's all kind of things you have to look at, just depending on what market you're in. But how do you structure your subsidies too, so that you're able to true this up? Because you can't just say, well, I'm going to pay you this subsidy. Well, how do we know what you're collecting? So you have to put a method in place in your contract to true this up. The way we've been doing it is we have our contracts truing this stuff up every month. They show us what their collections are as to what we've agreed on as the maximum monthly subsidy, and then you pay the difference between that. And obviously, your goal is to reduce it to zero, but that's been proved really hard to do.
Yeah, I mean, simple supply and demand there. If there are not enough anesthesiologists and not enough CRNAs, I mean, in a way, you can write your own ticket if you're that type of a provider. And you're mentioning the subsidies here. Just 2 weeks ago at HealthX in Nashville, the big McDermott PPM and ASC event, some of the numbers being thrown around for annual budgeting just for this anesthesia stipend, this anesthesia subsidy, it's not insignificant, even on a line item for a
Oh
big
no, it can be over $1 million.
tens of millions were some of the numbers I was hearing from
Wow.
some larger management companies. And they're going, we know to plan for this, but it just doesn't feel real that this is how much we are going to spend this year on anesthesia subsidies. And I don't know systemically what we need to do to fix that, because that's kind of a symptom of a broader healthcare economic system that works in some ways really well, and in other ways it's like, why are we doing this? Why is our cost of care so high? And I'm not sure this is the forum for me to solve all those problems.
Right.
But many more smarter folks than I on this podcast. But just simply the supply of anesthesiologists. Where do you even start to get more folks interested in that career?
Well, and you look at the proliferation of even ASCs. We now have like around 6,500 Medicare certified ASCs, but like 11,000 total ASCs that all need
Yeah.
probably anesthesia providers. So that keeps growing and growing. So the need for anesthesia keeps growing, and there's less providers because partly a lot of them, retired early after COVID, went and did something else because that was a pretty rough time for anesthesia providers. Very rough. They had to do a lot. I remember it clearly, and it was not pleasant for them. And then the Balance Billing Act, and they're not allowed to do certain things that they were allowed to do before that improved their reimbursement. So that's hurt them too. And then number one is really their reimbursement from federal government payers is so low. I mean, it equates to like $84 an hour. I mean, really? They had to go to school for a long time. So
The cost of drugs is greater than the reimbursement for the procedure.
what can we do about that? And that's something we're talking about a lot at ASCA. We talk about anesthesia at every board meeting because it's such a big topic and it's impacting so many, all of our ASCs, where it could, like you said, if your subsidies are so high, you may not be able to afford to stay in business.
Right. Well, this is obviously tongue in cheek. This is kind of a flippant comment, but the end point of all this is that there's not enough anesthesia to go around. Then procedures they're not going to be performed. I
Yeah,
mean,
because I don't think anyone wants to have any surgeries without anesthesia. Not,
put me on that list. It's
yeah,
not
I'm
happening.
thinking not likely.
It's not happening. And
Yeah.
then you called back to post COVID or coming out the other end of COVID and through it as well, and lots lots of different kind of stories for physicians and all types of providers through COVID, but that seemed to kind of be the straw that broke the camel's back initially, because just like this anesthesia shortage, there are, on a national average, a huge shortcoming of the providers needed to treat the amount of patients that need care. And prior guests of the show, and I'm sure we've talked about it as well, what do we need to do to get more folks interested in becoming a doctor, period? I've heard a lot of good ideas, but I have yet to hear sort of a silver bullet.
Yeah,
It's
I mean, it takes a long time. It's really expensive, so there's all that. And do we have enough medical schools, and how, because I think they're all full. As far as I know, it's still really hard to get into medical school.
right. Right. I haven't applied lately, but I've heard the same thing.
So I think it's pretty hard, and pretty hard to get into residencies and all that stuff. But how do we, it seems like we would need to expand the number of those type of things, medical schools, and the number of residencies and things like that, because otherwise, how are we going to get more providers if we keep the number the same of those, and they're all full, because I know they're full because I know people who try to reply to them, it, so
Some of the suggestions I've heard that, and I guess to zoom out a little bit, this isn't a suggestion. This is just market forces. But you kind of have this pendulum that swings back and forth over every 15, 20 or so years. Obviously, the amount of money being injected into big healthcare, if you will, by PE and other groups, that's probably unprecedented to this point. But you used to have this pendulum that go from employed physicians to independent physicians. If you're employed, you might deal with a little bit less autonomy than owning your own practice, obviously, but a lot less administration that you have to put up with as well, or administrative tasks is what I'm trying to say there. So you've got this balance that goes back and forth over time, but just the amount of time providers are spending on these administrative tasks. And I'm kind of looking at you, macro MIPS and quality reporting and all these different registries and all these things that take physicians away from being the physician that they would like to be. That's been one suggestion: lighten the administrative load on independent practices. The next is sort of tied to it: get them better software to use. Their core EHRs, aren't known to be the most friendly software that gets used. A lot of great friends and vendors in that space doing good work. It's the legislative requirements, the quality reporting requirements, which I'm kind of talking out of both sides of my mouth. I'm not opposed to that, but how can we make it easier?
right.
And
I mean,
finally,
even for ASCs, our quality reporting requirements are crazy. I mean, we're still reporting COVID vaccines and things like that, which doesn't seem to have a whole lot of value. And that's another thing that we work on at ASCA, is to try and, make these, if we're gonna have to do it, what is it being used for, and is it of value? Because it requires a lot of administrative time, and it's
sure.
difficult to do. And is it making any sense to do, or are we just doing this to do it?
Yeah. The classic example is the pediatrician's office asking a smoking status on like a 2.5-year-old, 3-year-old child. Like, I'm sure it happens somewhere and hopefully not often, but what are we doing? This kid's not a smoker. Like, they can't even, this
Right.
is such bad taste. They can't even light the cigarette. What do we do in asking these questions and being scored and reimbursed based upon their completion? Doesn't make sense to me.
Yeah, and some of the stuff for ASCs, it's like we see the patient that day and we do follow-up phone calls, but that's it. We can't be checking their eyes later and doing all these other things after they've gone. That's not what we do at ASCs. That's not the nature of our business. The nature
But
of our business is same day surgery. That's what we do. We don't,
get to go
we're
home and
not
not.
following these like the doctors are at their office.
No, right, right. So anyway, those are just a few of the high level things that I've heard. They seem to make sense to me, but we still have to address the bigger issue that people we can't produce enough physicians if we wanted to, or produce more than we currently are, and we need to drive more demand in that as a career. So that's a tough one. We'll have to come back to that. Maybe we won't solve that one today.
Probably not, but
And on the other end of this, we've talked about physician shortages and anesthesia shortages. What about staffing? Because coming out the other end of COVID, it's not easy to hire and retain good talent either.
no, I mean, during COVID, at the health system I was at the time, and at most other ones, I mean, the amount of agency staff that you had was just astronomical, and the amount of extra cost that was, you know, was to the health system in the United States. I don't even know what the dollar amount is, but for each individual hospital, it was astonishing. And even surgery centers that we never had to use travelers, you know, and we had to because we couldn't get enough staff, and travelers are like 3 times the price of a regular staff. So, that's obviously not something you want to do. And I think we've largely gotten back to normal where we don't have too many travelers. There's still some, I think, but one of the most difficult to recruit positions is a certified surgical technologist, and that is
Mm.
at the hospitals and at the surgery centers. And again, I don't know if there's not enough tech programs out there for them to get trained. I don't know, but it's been a huge shortage in that. And you don't want to pay RNs to do something that you can have surgical techs do necessarily. It's much more expensive to have RN. Can they do that? Yes. But, you'd rather get surgical technologists who can do it. But that's been the hardest position to fill everyone I've talked to in our health system for sure, and that's at hospitals and surgery centers. And then the next one is central sterile processing folks to do our instruments.
Mm.
It's gotten so very complicated to do that work, and the salaries that we pay these people are not awesome. They have to learn a lot and they have to know a lot, and it's hard to find these folks, and you need more and more of them because our requirements are so many. Plus we're doing complicated procedures that require a lot more trays and all this stuff, so you need more manpower in that sterile processing department. It's hard to find.
Well, just on the balance overall, so I heard you loud and clear. Surgical techs, really tough to come by. Sterile processing, also tough to come by. But on the whole, how are you seeing the COVID impact on staffing change now? It's 2025. We're almost halfway through the year. Is it getting better overall, staying the same,
I
worsening?
think it's certainly much better than it
Okay.
was, because again, you had to reach out and get travelers at surgery centers, which you don't want to do. But we still have like a little tiny bit of that, but much, much less. Now the salaries have increased a lot, which
Sure.
as a nurse, I'm glad for that, to see that the average salary of our nurses across the nation has gone up a lot um, since COVID. And because they had to keep the nurses, because it's a lot cheaper to pay our existing nurses more than pay travelers.
Oh, sure. Sure.
So I think, instead of nurses getting a 2 or 3% increase, most of them were getting 10+% increases as market adjustments, or, whatever, to their salary, because they had to do, the hospitals and the surgery centers had to do it to keep people.
Yeah, hard earned and well deserved, if you ask me.
Me too.
So,
Like I said, as a nurse, it's like teachers. I don't think we certainly weren't being paid enough for many years. And, it seems to be getting a lot better. And that will also attract more people to go into nursing.
well, that's a part of an organization's culture and a pretty big part. I'll admit to this. If I hit the Powerball this weekend, Rena, I'm not sure how many more podcast episodes I'm going to
Yeah,
record.
you might not be doing it. I get it.
But you mentioned something else too, that you don't necessarily want RNs fulfilling duties that are not, at the top of their license, for lack of a better term, to the height of
Correct.
their training. So that's also a really big part of culture. What are you doing to ensure cohesion within the team and helping to make folks work meaningful, beyond just the patient care? Because that's the point.
Well, one of the things, like you mentioned, working at the top of their license. I mean, RNs, if we can get them some patient care assistance, some aids and things like that in the pre-op PACU and in the operating room, that makes them so happy that they don't have, they can spend the time doing the things that they're trained to do. And they get helpers for turning over beds, turning over rooms, wiping stuff down, pushing patients out to their car in a wheelchair. All these kind of things that someone else could do. That, and it also, it makes that helps the culture, and it also helps the finances, because if you're not using RNs to do all those things, so you have to think about where can you use sort of those patient care assistants. And um, I think you can save a lot of money and also improve the culture. The most important thing too, I think, is celebrating successes and having little celebrations at the center, and making, the administrator, whoever's running the center, making the staff there feel like they really care about them as a person. And those are basic things, but that's really important. I mean, little lunches, little this, little that, asking them about their kids, being involved with them as people. And I think that's really important, so that it feels like a little family at the surgery center, because that's what makes us, one of the things that makes us unique from a hospital.
Oh, big time. And I mean, those are things that you want to do just as a decent person, as a good person. Like, you want to take an interest in the folks that you spend so much time with. But on the pure business side of this, if you've got a good culture, it may not be easy to hire that next surgical tech that you need, or that next sterile processor, but you got to be doing something to keep the ones that you already have. And obviously, this is line item management, not human, real human interaction. But culture goes a long way there, doesn't it?
Yes, and like I said, it's little things. They just like little things. They want to know they're appreciated. you
We
know
all do. I know I do.
Everybody does, but it's just little things. And I once had, my best mentor always said, do not skimp on food. That's never going to make your bottom line, and that's really important for morale. And it's true, because they really like food. I mean, if you have chocolate in your office as the administrator, or whatever the staff likes, and they know that little stuff like that, little rewards for things they do, you know that when they get called out in a good way on patient satisfaction surveys, what are we doing about that? Are we making sure everybody knows about that? And how can, and make it fun there, because you want to make it fun.
The food is really talking to me. I'm going to note this down.
Yeah,
Don't.
I had one place I went, and they go, oh well, they said we had to get rid of the coffee. I'm like, are they kidding? They had to pay, people were going to have to pay for the coffee. I'm like, no, wrong. No, that is the wrong strategy.
That's the worst possible idea
Worst
ever.
possible idea. In fact, my idea is to have the best coffee, because
Right.
if you've ever been to a hospital for special surgery in West Palm Beach, Florida, they have the best coffee maker, and the doctors will come down to the first floor to get the coffee because it's so good. But it's, just little things like that really make a difference.
Yeah, yeah. I'll make note of that. The next time I need a procedure done, I'll be sure to
You
go
go
get
in
one.
a hospital up in West Palm Beach, and the first floor lobby, they have the best coffee maker. I actually had one of our centers in Fort Lauderdale get a similar coffee maker. And
Okay.
you couldn't believe, they had like one of those old kind of coffee makers like you would see in a diner, with
Yeah.
the little pitcher with the orange for decaf and the brown handle for regular. And I made them get rid of that. And I'm like, get, I promise you. I mean, the response was unbelievable.
People will do just about anything for a good cup of coffee. And
They were, and the next time I visited the center, everybody was coming up. Oh, Rena, thank you. We are so excited about this coffee maker. I'm like, oh, look at that.
you're welcome. Yeah. Anytime.
I, in fact, I think I'll get a cup myself.
Yeah, don't mind if I do.
Yeah. Well,
Okay, so
in Miami, it's very important. If you don't have your Cuban coffee down there and your cafe con leche, you're going to have problems.
that's what's so funny about the coffee culture in Miami, is that there is always a pot of coffee on, and if you want something like what you just mentioned, cortadito, cafe con leche, you better call for it now.
Yeah,
Let's get
you
it
got to
going.
have the ability for that in those centers, because otherwise, I learned that when I first moved to Miami in 1999. I think I
Very
learned that
important.
on my very first day.
Oh yeah, everybody's running around down here, highly caffeinated. You gotta be. You gotta be.
Yeah.
So that's a really nice ray of sunshine for staff and on a culture note. But let's go macro. We talked about some kind of not kind of we talked about big problems that are already having an impact on the delivery of care today. It's not going to get a whole lot better unless something changes around physician and anesthesiologist shortages. But there's still a lot to be proud of in the ASC space. You know, we fly the ASCA flag very high and proud here at Doc Buddy. I know you do as well. Tell us some good news, Rena. What's going well in surgery centers?
Well, I think what's going well is we continue to be the beneficiary of, procedures migrating out from the hospital. And the hospitals really need to focus on what they do well, and people need the hospital. They're always going to need the hospital, and making room for those high acuity procedures that can't be done anywhere else. And I work for a hospital company, but we know that at our executive leadership level, we have to move these things to the appropriate sites of care. And so we're getting all the things, we've been the beneficiary for many years of total joints, and that just keeps increasing and increasing. And it's projected to be like 60% of all the total joints in the, next few years. That's been a really successful migration of something that was always done in the hospital. That's exciting, is migrating those things. Cardiac a little slower, but also, insurance companies, United really took the lead on it to have a list of thousands of CPT codes, really, or hundreds, but that they only will pay for at the surgery center unless there's a really good reason to do it elsewhere. I mean, you have to justify it if you're not going to do it at the surgery center, and that helps move things in the right direction. And probably I would assume other insurers will get on that bandwagon. Aetna has a little bit, but then you have Medicare, where we are constantly focusing at ASCA on how do we sort of more equalize the playing field. We have some good momentum. We have some potential legislation uh, um, to put a cap on the co-pays for Medicare for ASCs, which is interesting that, Medicare, in their infinite knowledge, has removed for hospitals and hospital outpatient departments. They have a cap. So patients could actually pay less to have a total joint in the hospital than they would the surgery center. And that just is contra, it just doesn't make any sense. So we're working hard to get that kind of fixed, because it makes all the sense. And I've never talked to a legislator yet. We met with one when we were in Denver, and they're like, well, that makes all the sense. Why would we not do that? But what happens to get it actually passed is they always want to put it in with some other legislation, and then that's what makes it more tricky to get passed. But we feel like we might have a good shot to get this passed.
Well, I hope you have more than a good shot. I mean, as a healthcare consumer myself, and just seeing the amount of money that we spend on healthcare, it's a no brainer. It doesn't seem like a no brainer. It is. So, definitely don't air out any of CMS's dirty laundry here. But why is it
Yeah.
taking until 2025 to have this be under serious consideration?
Well, one of the issues was really it didn't really bubble up, until we started doing more of the high acuity procedures, because the cap never came into play with most of the stuff we did. Like that wouldn't have come into play anyway. It's when we started getting into more high dollar procedures like total joints pain stimulators, things like that, that we started seeing, oh, wow, if you don't have a secondary insurance, you're going to pay more to have that procedure at the surgery center than you are at the hospital because of this cap situation. And it was really it's only the high acuity expensive procedures, you know.
Okay. My spear is sharpened and it's always ready to be thrown CMS's way, but
Right.
that sounds kind of reasonable. I'll give them a pass
Right.
on.
So, I mean, I think it's only been like a really prominent issue for the last few years. So we've been working on it. But like, I never even knew about it until, again, we started doing these higher, we call it implant intensive, device intensive procedures, is what they use at CMS. So that's what's driven it. And then I guess they didn't think about it, and now they got to figure out how to fix it.
It's always those second order consequences that are so tough to
Yeah.
foresee sometimes. Okay, so that's good. Those are some really nice rays of sunshine there. And as we kind of get to the end of our chat today, I know there was a couple thoughts on AI and healthcare we wanted to cover. It doesn't have to be any type of expert opinion. I certainly don't have an expert opinion, but I have a lot of thoughts on it. How do you
Okay.
see AI and healthcare
Well,
going?
and again, I don't have any expert opinion either because I have limited experience, but I think we can use it a lot in our administrative functions in ASCs. That's how I see it fitting very easily and pretty quickly into what we do, whether it's, appeals for claims, writing appeals, whether it's coding, things like that. We have oftentimes hard time finding, coders, certified coders to do the coding, and it seems like, boy, AI would be a great uh, application for that, and really eliminate and make it faster to get your op reports coded, get your bills out the door, things like that. So administrative stuff, taking minutes for meetings, I've seen, where people have used that. And how do you use that to, we all have to take minutes for our medical executive committee meetings, our governing board meeting, quality committee, all these things, and you have to put them into nice pretty formats for the accrediting bodies. And that's probably a good use of it too.
Yeah, I know you're right about that. And for any of my providers out there, my doctors, my surgeons, or otherwise, don't be putting PHI into something like ChatGPT. I know that's not what you're suggesting, Rena, but
No, 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 no. And that's we can't. We just I just did our training for our annual like IT training, whatever, and that was on there. Like we don't do, because people don't think like, okay, you can't put that in Chat GPT because then it's going to be out there.
yeah,
It's going to be explorable.
scary stuff. People just don't know. Although I'm sure this doesn't happen at any of the organizations you work, but the emailing of completed operative reports around, we hear about that from time to time. Not good. Got to be.
No, no. And then, the other thing that happens is surgeons want to take pictures with their cell phone, like in the OR. No, they're not supposed to do that either. That was on the training also. You can't, that was
Yeah.
on the HIPAA training. The HIPAA training, you can't do that.
Can't do that. Can't do that. Not unless you got an app like DocBuddy. I can't resist there. There's a right way to do it. Unless your
Yeah, but your
organization just
cell
tells you
phone and
don't,
then sending that no, no,
don't do it.
no, don't
Just
do it. I've had to counsel a few doctors on that, and they're like, well, why? I'm like, oh my God, why? Let me list the many reasons why.
yeah, it sounds like you need a refresher on the
Yeah,
PHI security training there, Doc.
I know. It's like, oh my God. And I just did all that, like the HIPAA training plus
Uh-huh.
all the IT training, and so it's fresh in my mind. But the examples they were showing, it's like, yeah, people are really doing that stuff still, even after all the years we've had HIPAA.
It's a good compliance training when they give you an example and you're going, "Oh my gosh, who would do that?" That's a shocking abuse of PHI.
Right, right, yeah. But it's easy to forget sometimes. People get we get complacent with what we do, and then it's like, oh, but these are very serious problems if you do it.
Yeah, very very serious. Very serious is right. So, Rena, any closing thoughts? Is there anything we wanted to cover but we didn't?
Oh gosh, we could talk all day, about different things, but I think we covered a few variety of topics.
Yeah, we made a good run at the some of the most pressing challenges around physician shortages and anesthesiologist
Yeah, I mean,
shortages.
the only other thing we might have talked, we said we might mention, was cardiovascular procedures moving into the ASCs, and I think it's one of those things where we've heard that that's going to happen for many years. And back in 2010, I know my center started doing pacemakers, defibrillators, cardiac rhythm procedures, and then we actually lost those because those cardiologists became employed. And when you look at the number of cardiologists who are employed, it's one of the highest specialties that's
Mm,
employed. I think it's close to 80%. And so it's tough for, ASCs, unless they're part of that health system. So that's probably one of the biggest barriers is employment. But the second is state regulations, because a lot of states still don't allow anything but cardiac rhythm procedures at ASC. So even though CMS has put in some of the interventional cardiology on their list that's approved for ASCs, states still don't approve it in many cases. So I see that's changing a little bit, but it's been a little slower than I think people thought because of mainly those two things.
Sure. And this is just a point of curiosity. Why do you think that such a high proportion of cardiologists are employed as opposed to independent?
I guess, to me, it's just because most of it lends itself to hospitals, and their patients are in hospitals and they're doing rounds on their patients. And, they have a lot of, inpatients, plus the interventional procedures. I think a lot of providers are reluctant still, and certainly were, to do it if it's very far from a hospital. Because what if you find something and you have to take the person for, that's a common thing I hear. Well, you have to take them for open heart or whatever, or further
Mhm.
interventions, and they worry about that.
That's fair, and I'm glad they're thinking about it that way. Even I referenced him before we started to record. Dr. Dan Blumenthal with CVA USA, was saying some of the same things. We haven't tried this in the ASC yet. It'd probably be fine, but my thought back, and this is just kind of tongue in cheek again, like I'm not going to be the first one. Like, are you? You going to be the first one to do it in ASC? Like, no, I'm not. Okay,
Well,
so
and
who's going
kind
to
of
be the
total
first one?
joints was like that for a long time, and spine still is to some degree. Some doctors still aren't comfortable doing spine in the ASCs. Like I'm talking about ACDFs and things like that, multi-level ACDFs and more advanced. I mean, some are, but some still aren't. So it depends on what your comfort level, what your training was, all that stuff. So I'm
Sure.
sure it's going to keep evolving, and it'll be interesting because I have a few that want to explore, and they're employed groups. They want to explore having a freestanding CVASC, and I know there's many in the country, but I think it'll continue to grow.
Yeah, pushing the envelope, always innovating. Gotta like that. Well, Rena, it's been so much fun to have you back on. Before you go, where can listeners connect with you?
Well, I'm on LinkedIn. Um, so I'm happy to connect with anybody on LinkedIn. And then, you know, that's the easiest way, I'd say, to connect with me.
LinkedIn's always a winner, and obviously you can see the work that she does at the ASCA website, which I'll get a link to that into the show notes, and you'll see all the great work that ASCA does advocating for surgery centers nationally. And is there anywhere else to point people to, Rena, or is that a pretty good shake?
That's pretty good because, you know, I always respond if somebody messaged me on LinkedIn. So
Perfect. Well, thank you again for coming back to the show. Really enjoyed our chat again.
thank you for having me. I enjoyed it as well.
Oh, it's totally our pleasure. And on behalf of the entire Doc Buddy team, we want to thank you for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube so you always get the newest episodes of the show. And until next time, I'm Eric. Talk to you soon.